Thank you for your interest in the PAC, the activity measure for post-acute care. The following presentation serves as a general introduction to the PAC. The PAC was developed at Boston University's Health and Disability Research Institute by Drs. Alan Jetty, Stephen Haley, Wendy Koster, and Peng Shang Ni. The PAC is currently being used in research and to monitor outcomes for quality improvement. The PAC can be used in all patient care settings, including inpatient rehabilitation, skilled nursing facilities and long-term care, outpatient rehabilitation, and home care. The PAC was developed to address a significant problem with current outcome measures. The field lacks a comprehensive measure that can be used across different care settings. The PAC is unique because it was specifically designed to be used across all care settings. The current practice of using measures developed for specific care settings results in the inability to examine patients' functional status when they receive care in more than one setting. For example, outcome measures used for inpatient rehabilitation, such as the FIM and IRF-PI, cannot be compared to the MDS, which is used in nursing homes, or the OASIS, which is used in home care, and there is no agreed-upon measure for the outpatient setting. Without a single measure that can be used across all post-acute settings, it is impossible to monitor functional status during an episode of care as patients move across the continuum of care settings. Researchers at Boston University developed the PAC with the goal to create a single measure that can be used across all post-acute care settings. The PAC is a patient-reported outcome measure. There is growing interest in patient-reported outcome measures because they capture the patient's perspective and therefore provide an important and compelling measure to assess post-acute care. The PAC is conceptually sound. Items were developed based on activities described in the World Health Organization's International Classification of Functioning, Disability, and Health, commonly referred to as the ICF. The ICF framework grounds the PAC instrument within an accepted conceptual framework for disability. PAC items were developed after conducting extensive focus group sessions with patients and clinicians. This process helped to ensure that activities that are important and relevant to patients are reflected in the PAC items. The PAC items were tested in different care settings and involved a large sample of patients with a range of different diagnoses. The PAC includes 3 functional outcome scales, or domains: basic mobility, daily activities, and applied cognitive. The PAC consists of 269 items, which are divided among the 3 domains. The 131 basic mobility items include items that assess the ability to ambulate or use a wheelchair, transfer, bend, and lift and carry. Daily activities include 88 items that assess eating, meal preparation, grooming, and dressing. The 50 applied cognitive items include items that assess the ability to communicate, use print information, and follow complex instructions. Any or all of the 3 PAC domains can be selected based on the characteristics of the patient population. For example, in a research study or clinical setting that includes patients with neurological disorders and cognitive impairments, all 3 PAC domains would be included. However, if the patient population is comprised of individuals with orthopedic conditions and no cognitive impairments, only the basic mobility and daily activity domains would be administered. Each domain takes only 2 or 3 minutes to complete, and you might wonder how the hundreds of items included in the PAC domains can be administered in only a few minutes. This is where the PAC's use of sophisticated technology comes into play. Clearly, a large number of items with a wide range of difficulty are needed to assess the functional abilities of patients who receive services in different post-acute care settings. For example, in the mobility domain, there would need to be items that are appropriate for all levels of functioning, from learning basic bed mobility to returning to competitive sports. All items must be included. Using traditional approaches to measurement, the instrument would have to be so long and so burdensome that it would be impractical to use. The PAC solves this problem by using computer adaptive testing. With typical standardized tests, all items must be completed by all patients, even though many of the items are irrelevant and do not provide information about how that person functions. However, with the PAC computer adaptive testing approach, a computer program selects appropriate items from a large bank of calibrated items. When the individual responds to an item, the computer program selects additional items that match that patient's ability level. With this approach, each of the AMPAC domains can be administered in just 2 to 3 minutes. This is how the AMPAC is able to provide a precise estimate of an individual's functional ability without being burdensome. Now let's look at a schematic diagram of how the AMPAC computer adaptive test works. The process begins with a calibrated item bank for each domain. The item selection process begins when the patient responds to the first item. A preliminary score is calculated, and the program checks to see if a predetermined stopping rule is met. The AMPAC stopping rule can be set to administer a specific number of items or reach a desired confidence interval, depending on the preference of the clinical setting or research team. Additional items are selected until the stopping rule is met. The program then provides the final functional score estimate and the precision of the estimate. It might be helpful to picture the AMPAC items as they would be located on an imaginary ruler. The ruler can be divided into 3 areas of difficulty: low, moderate, and high. When the AMPAC basic mobility domain is administered, the first item is, how much difficulty do you have bending over to pick up a piece of clothing from the floor without holding on to anything? In this example, the person responds a lot. Based on this response, the computer calculates a functional score estimate of 62 with a confidence interval of plus or minus 15 points. Based on this response, the computer program selects the next item. How much difficulty do you have walking around inside a building, 50 feet, on the same level? And the response is a lot. With this additional information, the computer program calculates a new functional score estimate and confidence interval. The next item selected is how much difficulty you have walking on an uneven surface, and the response is a lot. The estimated functional score is 53, and the precision has improved to plus or minus 7 points. For the next item, how much difficulty do you have doing light housework? The response is a little. Now the functional score estimate is 52 plus or minus 5 points. In this example, the stopping rule was set for precision with a 5-point confidence interval, which has now been met. So the program stops, and this is the final score. One of the strengths of the AMPAC is that it produces a quantitative score, and since the scores are on the same metric or ruler, they can be compared within and across individuals with different levels of functioning. Furthermore, these functional scores can be described within a clinically meaningful context, which is particularly helpful when communicating with clinicians, patients, and families about a person's functional ability. Scores are grouped into 5 different stages. Stage 1 is at the lowest level of functional ability, and Stage 5 is at the highest. We will demonstrate these functional stages in the mobility domain, but it is important to remember that stages have also been developed for the daily activity and cognitive domains. In this example, an individual with a basic mobility score of 72 would be categorized as having a mobility profile at Stage 4. The characteristics of an individual with a Stage 4 mobility profile are: the person is independent in mobility within a room and in a building, is mobile in the community but with difficulty, and can do some sports and recreational activities but with considerable difficulty. AMPAC mobility stage profiles are organized into different activity categories. As you can see on the y-axis, there's a list of activities that range from the most difficult, vigorous activity at the top of the y-axis, to the most basic, use the bathroom, which is at the bottom. Each activity is then broken down by typical responses for these activities based on the mobility score. As the items become more difficult, persons with lower mobility scores respond that they are unable to do the activity, while persons with higher mobility scores can do more activities without any difficulty. The rehabilitation field needs measures that are sensitive and able to document changes in patients' functional status. The AMPAC has been assessed in rigorous studies, and all 3 functional domains were found to be sensitive to change across 1, 6, and 12 months of follow-up. The AMPAC sensitivity to change compares well to other patient-reported and performance-based measures. The AMPAC was developed with funding from the National Institute on Disability and Rehabilitation Research and the National Institutes of Health. It has been chosen by the Centers for Medicare and Medicaid as a core element of the assessment tool for the Outpatient Prospective Payment Project, and it has been endorsed by the National Quality Forum for the Medicare Pay for Performance Program. The AMPAC has been used to monitor clinical outcomes for inpatient and outpatient settings. The AMPAC has also been used as an outcome measure in several research projects. You can learn more about patient-reported outcomes in the AMPAC by visiting our website.